Hello, everyone. It's wonderful to have so many of you with us today to learn more about the pathway to accountability, compassion, and transparency, or what we call the PACT Collaborative. Nicole, can you advance to the next slide? Great. My name is Melissa Parkerton, and I am the director for the PACT Collaborative. And we are joined today by Allison Perry, Evan Benjamin, and Tom Gallagher, who are our faculty for today. And I will introduce each of them as we get to the section that they are going to be presenting. Next slide. So today we are really going to go through an overview of the PACT Collaborative, what this is. We'll talk first about what a highly reliable CRP or communication resolution program is and why it matters. We'll talk about how you leverage the Breakthrough Series collaborative model for collaboration and improvement and ultimately spread. And we'll talk about what PACT is and why we think this might be a good opportunity for you to join. We'll finish up by talking about some of the program specifics, the application selection process, and then we will open it up for any and all questions that you may have. As we go through today, please feel free to put questions into the chat and we'll be sure to address them when we get to the end. And at the end, it'll also be fine for you to unmute and ask your questions live. Next slide. All right, it is now my pleasure to introduce Thomas H. Gallagher. He is a professor in the Department of Medicine at the University of Washington, where he is the Associate Chair for Patient Care Quality, Safety, and Value. He is also the Executive Director of the Collaborative for Accountability and Improvement, an organization dedicated to the spread of highly reliable communication and resolution programs. In 2017, his work advancing communication resolution programs was recognized with the receipt of the John M. Eisenberg's Patient Safety and Quality Award for Individual Achievement, presented by the National Quality Forum and the Joint Commission. Tom, I hand it over to you.
Thanks, Melissa. It's really wonderful to see everyone here today. I've been working for the last 2 decades focused on this issue of how can we respond more effectively in healthcare when something has gone wrong. As clinicians, that's obviously the last thing that we want to happen, is for patients to be harmed by the care we intend to help them. But harm is inevitable, and unfortunately for many years, our response to that harm just ended up making things worse for patients and families, worse for clinicians, worse for organizations. And PACT is so exciting to me because we're in the midst of a transformation in how we respond to harm events, and PACT really represents the culmination of that transformation. On the next slide, I just sort of point out that when we think about quality and safety in healthcare, I think we've made important progress, which is great, but we've not made nearly as much progress as any of us would have hoped. And why is that? That's in large part because when something goes wrong, when patients are harmed, we're not always open, we're not always transparent, we're not always learning. And that's really it's really the fundamentals of what communication and resolution programs are about, ensuring that when patients are harmed, we're open with the health system, we're open with fellow clinicians, we're open with and supporting patients and families, and we make sure that harm events drive learning. We struggle to respond to harm events on the next slide for several reasons. A lot of this is just human nature. Think about the last time you were involved in something that went wrong, either personally or professionally. It's natural. We all come hardwired from the factory with this inclination to want to keep problems to ourselves, to avoid difficult discussions. We worry and are afraid about punitive consequences. We're afraid, we're embarrassed, we don't know what to say. Even at organizations that have been working hard on improving their response to harm events, clinicians still get mixed messages. Mixed messages like, of course we want you to tell the patient about what happened, but don't say that. For anxious, afraid clinicians, those types of mixed messages just further exacerbate this tendency to keep information to ourselves. And most importantly, we're seeing in the field organizations struggle because the different elements of their response to harm are not sufficiently hardwired. So they don't happen consistently and reliably every time patients and families are harmed. The way we respond to care matters deeply. These inclinations that we have can either support or inhibit effective responses when patients or families are harmed. The helpful inclinations we have is we want to be open, we want to comfort the family, we want to apologize, we want to keep things from happening again. But those are mixed with and oftentimes overwhelmed by these less helpful inclinations and reflexes to not only want to keep information to ourselves, but to rationalize and minimize and blame. Usually in healthcare, we don't have a choice when it comes to patients and families experiencing harm, but we do after harm has occurred. We have a series of choices as clinicians, as organizations that we can make. And we have a fundamental obligation to make choices and to respond to harm events in ways that support patients and families rather than traumatize them further. Because when we don't do a good job of this, the consequences of failed responses to harm events are multiple. It takes the suffering of patients and families and just makes it infinitely worse. It increases the distress of clinicians. The literature is clear that a response to harm events that's ineffective makes litigation more likely when we don't do a good job of responding. We lose the opportunity for learning. Ultimately, highly reliable CRPs are about a strong culture and climate of patient safety. And when we respond to these events inconsistently, or we tell patients about harm events when we feel like it, or when we think they wouldn't, they're already aware of what happened, that just degrades the institutional culture and climate further, and ultimately reduces the public's trust in both the quality of healthcare and our ability to identify and respond to problems in healthcare effectively. And what we end up with is something like this gentleman who's in the false apology greeting card section, trying to choose between I'm sorry you feel that way, I'm sorry you got mad, I'm sorry you're such a loser. Not that any of you would say this to a patient or family after a harm event, but oftentimes the words that come out our mouths end up making things far worse, far worser, if that's a word, for patients and families. So what's a communication and resolution program? I'm going to call up a couple of you randomly on your cell phone and ask you this question, and here's the answer. Communication and resolution programs are comprehensive, principled, and systematic programs for preventing and responding to adverse events. Each one of those elements is essential. They're comprehensive. They start with culture and climate of safety, early event reporting, go all the way through financial, non-financial resolution, care for the caregiver, etc. They're comprehensive. They're principled. We use them every time there's a harm event. They're systematic. All those different elements are hardwired to work together, which is really hard when the response to harm events lives in silos in quality, safety, claims, patient relations, etc. Ultimately, the organizations that are seeing the most success with CRP are the ones that recognize that there are quality and safety initiative that have a claims reduction benefit rather than seeing a CRP primarily as a way to reduce their liability claims. Well, the elements of a CRP are listed on the next slide: early incident reporting, ongoing and open communication with patients and families, event analysis and quality improvement that focus on just culture, system solutions, and disseminated learning. A subset, and it's probably 10% or less, of harm events are due to error or system failure. But in those cases, where harm is due to error or system failure, the CRP model includes proactively making an offer of financial resolution rather than requiring the patient and family to file a malpractice claim. Care for the caregiver is critical. Far too often, when clinicians are involved in harm events, we just put our heads down and move on to the next patient. Not good for the clinician, not good for the next patient that they're rounding on. And ultimately, CRPs are about making patients and families the centerpiece of the response to harm and focus on extensive and ongoing patient and family involvement. There are multiple benefits of a communication and resolution program. When this works well, it preserves patient and family trust, clearly meets their expectations. We and others have done multiple research studies demonstrating that patients and families almost universally expect a CRP response when they've been harmed by healthcare. It lowers the distress of clinicians, lowers the likelihood of litigation, drives learning, improves our culture, increases the trust of the public and healthcare. So a wide range of benefits. And this is in part why we're seeing so much adoption of communication and resolution programs. 5 or 6 years ago, we could have counted on 2 hands the number of organizations that really had a communication and resolution program. And now we estimate that over 400 healthcare organizations and several liability insurers, which is great, are adopting CRP. We're seeing the CRP model spreading to new care environments like the senior care environment, which is one of the focuses of PACT. Children's hospitals, another focus of PACT. Outpatient care, small physician groups, rural and critical access hospitals. There's not a single care environment that isn't appropriate for a communication and resolution program. Another reason why we're seeing such rapid adoption is that there's been a growth in tools to support high fidelity implementation and drive quality improvement. Tools like resources and guidelines and training mechanisms for responding to CRP more effectively. There's a growing interest in hardwiring CRP into risk and patient management and patient safety software solutions. There are growing CRP learning communities, which is great, and supportive state laws in Oregon, Colorado, Massachusetts, and Iowa, as well as supportive legislation that's being introduced in multiple other states. Although I will say supportive state legislation is nice, but by no means essential. But why we're so interested in PACT, in spite of all of this uptake, is the challenge of inconsistent implementation. And that's the number one challenge in the CRP field. This involves either using the CRP for some cases, but not others, or using some elements, but not the whole CRP model for an individual case. And this is such a challenge to the field because it drives concern amongst skeptics that CRPs are really a claims management strategy. And it raises doubt about, well, how committed are we to transparency, to safety culture, to complying with important regulatory reporting requirements at the national and the state level? But ultimately, the reason why inconsistent implementation is such a threat to the field and is the number one issue that PACT seeks to address is that when we implement CRP inconsistently, ultimately fewer patients, families, clinicians, and organizations benefit from the CRP process. So having a highly reliable CRP is critical to responding to patients and families after harm event. And I'm going to pass things back to Melissa so you can hear a little bit more about how a breakthrough series collaborative can really drive that highly reliable CRP implementation. Melissa?
Excellent. Thank you, Tom. I would now like to introduce Allison Perry. Allison is a director at the Institute for Healthcare Improvement, IHI, and she previously served as a director for the National Patient Safety Foundation from 2005 until 2017, when the foundation merged with IHI. Allison holds a master's in cultural anthropology and is a graduate of the AHA NPF Patient Safety Leadership Fellowship. Ms. Perry's extensive patient safety work has included the creation, management, and oversight of numerous IHI NPSF publications, patient safety seminars, and educational material. She developed and led the first NPSF Learning and Simulation Center and has facilitated the integration of simulation into educational programs across NPSF and now IHI. Allison, I turn it to you.
Thank you, Melissa. Let me know if my sound needs to be adjusted at all, but I'm happy to be here with all of you today and to talk not only about what is a Breakthrough Series Collaborative, but specifically how we'll be using the Breakthrough Series model to collaborate, improve, and spread communication and resolution programming. I'll start with a quote from Goethe, that knowledge is not enough, we must apply. Willing is not enough, we must do. Next slide, please. So this quote describes nicely why the Breakthrough Series was even designed. It was designed in 1994 when one of IHI's two of IHI's founders, Dr. Paul Batalden and Don Berwick, they were at a meeting and like many of us do, were sitting together and sketching ideas out on a napkin. And they sketched this idea out onto a napkin that you'll see here on the screen. And it was designed because they were discussing how successful IHI had been in training thousands of people from hundreds of healthcare organizations. Fundamentally, how do we improve? And there was a lot of knowledge and there was a lot of will for improvement work. But the question was, so how do we help people get this done? How do we help them do this work to make real system level changes to impact care? So this was the method that they designed. And from there, the Breakthrough Series collaborative model was created. And while I go through this next part, I would love it if you're able to chat in here. If you've ever participated in a collaborative, whatever the topic might be, and if you'd like to share, you could share the subject matter or the innovation. But I'd love to hear from you if you've ever participated in a collaborative. You're probably all very familiar with what it means to collaborate, essentially a joint effort among multiple individuals, or in this case, organizations that share resources and information. And a Breakthrough Series collaborative model is based exactly on that word collaborating. And key to this model is ultimately each organization benefits as individual organizations, even though you're all working together. So it's an improvement method that relies on spread. It starts with an improvement opportunity, in this case, communication and resolution programs. It relies on the spread and adaptation of existing knowledge. And that's an important point to highlight here, that we come to this work with existing knowledge. A Breakthrough Series is not an innovation model. That's not this space. We're actually going into this with existing knowledge. And that's how we can get the results that we get in a relatively short period of time. So in this case, for the PACT Collaborative, we have expert faculty who have the knowledge and expertise around CRP best practices. As Tom said at the beginning, he's been doing this work. He's been in this space for the past 2 decades. Dr. Evan Benjamin has similar expertise. And I've had the pleasure of knowing both of them and working with them in the patient safety world for over a decade. And probably the last 8 years on communication and resolution programs. So it's important to note that we have the knowledge, and then it's not just in one setting, which is why we have all of the organizations that we bring in to participate from around the country, all committing to accomplishing a common aim. It is important to note that, of course, we'll see adaptation. Every change idea is not specifically going to be done the exact same way in every organization, but we go into it with the same knowledge. However, teams take those ideas and adapt them locally and spread locally. Next slide, please. So this is our PACT model based on the traditional Breakthrough Series collaborative model created all those many years ago. And you'll notice that it's not that different from the original napkin model. If we were to go back and look, it's very similar. And this model has traditionally been a very robust model, which is why when we were designing this PACT program together, we felt that this was the best model to work from, so that we can take the existing knowledge that we have and plan for and engage with a wide number of teams across multiple organizations. So you've heard from Dr. Tom Gallagher about what is a highly reliable CRP and why does it matter. This is the model that we'll be working from as we deliver this content and work with you to spread this improvement. And next, I will hand it back to Melissa, who will hand it over to Dr. Benjamin, who will walk you through a more in-depth look at the PACT program and why you should join. So Melissa.
Thank you, Allison. So now I would like to introduce Dr. Evan Benjamin, who is the Chief Medical Officer at Ariadne Labs, a joint center of healthcare innovation at the Harvard School of Public Health and the Brigham and Women's Hospital. He's also an associate professor of medicine at the Harvard Medical School and at the Harvard School of Public Health, where he teaches healthcare systems quality improvement and patient safety. Dr. Benjamin was co-chair of the Massachusetts Alliance for Communication and Resolution After Medical Injury, sometimes called MACP, a 6-hospital alliance in Massachusetts to promote communication and resolution programs. His research focuses on the impact of CRPs on patients and providers, as well as on outcomes and cost of care. Evan, I turn it to you.
Thank you very much, Melissa, and I hope you can hear me okay, everyone. It's a real pleasure to be here today. I can't tell you how excited we are about the PACT Collaborative. We have been, as Tom had mentioned, working on this for the better part of our careers, really thinking about ways to improve the accountability and the transparency around harm. And we finally were able to bring together our knowledge, combining it with tools and resources, and now to really work with nationally leading health systems to really adopt and advance the concepts of CRP through this collaborative. So as Allison mentioned, what the collaborative is set up like a typical Breakthrough Series collaborative structure. We will have 5 learning sessions. Given COVID, we will work virtually, and we will have action periods which exist between these learning sessions with coaching from our faculty and other recognized experts, with regular check-ins, as well as the opportunity to really come together as in a learning collaborative where we are taking the tools, applying them, and then coming back and talking about what worked and what are the opportunities for further improvement. Through case-based discussions, we'll talk around specific ways that our tools can be applied to achieve the goals. Next. So what happens when you are a part of this? Well, first of all, we're really looking for providers and health systems that really want to be national leaders, who are already been thinking about patient safety very seriously and have been thinking about how do we manage harm events. By participating in the PACT Collaborative, there'll be a lot of opportunity for individualized learning from our core faculty, from subject matter experts, and from improvement advisors at the IHI. We will be working together. We spent the better part of the past 2 years designing tools to actually advance and use the concepts to understand how to actually implement CRP. And we put together a standardized a portfolio of metrics. These metrics we believe are really important to know how well the CRP program is being implemented and where are the opportunities for learning. As I mentioned, there'll be extensive shared learning opportunities with case-based discussions, and then very specific content. We anticipate, as Tom had mentioned, some cohorts. Our largest cohort will be the acute care cohort, larger health systems participating there, But we're also going to have a cohort for children's hospitals, which are dealing with slightly different issues, both with around harm and communication, and then a senior care cohort and organizations of long-term care facilities, again, which are dealing with slightly different issues. So through those cohorts, we'll be able to create this learning collaborative. Next. You saw Tom and heard from him already. I'm going to bring my expertise, which is a combination of a lot of very practical work as the Chief Quality Officer for a large health system here in Massachusetts for many years, as the co-chair of MACP, and now really thinking about implementation and scale at Ariadne Labs, all focused on CRP. Tom and I will act as the core faculty, but we also have a lot of other faculty and subject matter experts who will be part of our program. Next. As you saw, it's really three organizations coming together. Ariadne Labs, where I'm the Chief Medical Officer, really has been thinking about not only communication and transparency, but how do we think about implementation and scale? Tom from the University of Washington and the Collaborative for Accountability and Improvement has been really researching communication and transparency around resolution for many years and advancing that work. And then IHI, as you heard from Allison, with their expertise in collaborations and in the breakthrough series technology. We're very excited about the three of us coming together to lead this work. Next. Each team that will be part of the PACT Collaborative will come together. There'll be an executive sponsor, often a very senior leader in an organization, a leader who has responsibility over either quality or safety or risk, claims, patient relations, somebody who's really has a invested interest in these departments and in their performance. There'll also be a team leader who's responsible for day-to-day activities of the collaborative itself. A clinician champion, which could be a nurse or a physician, somebody who's closer to the front lines, managing quality, safety, and or cases related to harm events. We are very happy to be having patient and family representatives. But we've had a PFAC from the Collaborative for Accountability, part of our design team, and it's really transformed the conversation, and so much so that having patients and families is going to be a big part of each of the collaborative teams. And then there'll be other key staff members that will be asking you to tap people really working in the different departments that are affected. An effective CRP program touches on various departments: quality, safety, patient relations, risk, claims, and clinical content. And these key staff members will vary from organization to organization, but all be related to the processes of CRP. So these sessions will be virtual. There'll be really no limit for the number of participants, but there will be a core team that will be responsible for the work itself. Next. Our curriculum, if you look at our acronym, the Pathway to Accountability, Compassion, and Transparency. That's how we came up with PACT. That really is guiding our curriculum development. In fact, we've made a driver diagram for our curriculum, which really comes back to these primary drivers of how do we create accountability, which includes the learning about error. How do we create compassion in the way in which we communicate with patients and families? And how do we move towards transparency for our performance and transparency around harm events, which then includes also moving towards resolution. So this curriculum is really being addressed in our PACT curriculum. We will have a number of, in these learning sessions, gradually rolling out these elements of the curriculum. We're going to start with really talking about leadership. And as you can imagine, doing this well requires a really engaged leadership. Leaders who understand that this is not a tool for risk management. This is not a tool to lower costs of care, although there's evidence we do see improvements in claims, but it's really around that this is a mission critical project to really get to improving compassion and transparency for patients. We'll have other curriculum things such as actually mapping out CRP processes and seeing where they would fit within your organization. Better ways to communicate effectively. We find that, as Tom had mentioned, these are difficult conversations. And so we've created some conversation guides of how to actually implement the first part and the ongoing communication with patients and families. And then our curriculum around the comprehensive culture, which is necessary, and how do you create and then take advantage of that culture in doing our CRP programs. Next. These are some of the tools and resources. I mentioned some of them already. The mapping tool to see all the different elements, the communication, conversation guides, checklists, and then ways in which to measure what we're doing. And I just to pause on that for a second. Measurement, I think, is really important because it's very difficult to implement these programs. And once they're being implemented, to track how you're doing and seeing where there are opportunities is really a path for success. Next. These are just some of the steps that we'll be going through in our collaborative. I mentioned engaging leadership and the importance of that. And it's really giving the language around CRP and around CRP, which is now mission critical for the organization. We talk about context and readiness. I'll mention that in a minute. I want to share with you some of our thinking that Ariadne's been doing for a while to think about how do we adopt new initiatives in quality and patient safety and the importance of understanding the context and the readiness of an organization. The metrics I had mentioned. And then finally, how do we incorporate all this into workflow? And because each organization is slightly different, understanding the workflow and then incorporating these CRP process steps becomes so important in terms of the day-to-day. How do we make our CRP comprehensive and systematic? Next. So we think a lot about implementation at Ariadne, and we've put together a framework that makes us assess when anytime we're doing something new, what are the important elements? How do we know if an organization can adopt a new tool, whether that's a CRP process or perhaps a new checklist for improving patient safety? This framework includes these domains of leadership, culture, processes, meaningful measurement, all on top of this foundation of person-centeredness. Next. So we will be assessing all the organizations. They'll participate in our implementation assessment. This is what we call our context assessment, that in a very short survey assesses how an organization is around leadership, which gets to governance, where governance will, how it will be structured for the PACT Collaborative, whether there's accountability, both individual accountability as well as leadership accountability for the team members and how they'll be tracked, and how committed is the organization to getting this done, both at the leadership level and also the front lines. Is this being prioritized? We'll assess culture and context here. Of course, culture, so important. When we talk about the foundation for patient safety, we talk about having a culture of safety, psychological safety, a culture of transparency. We'll actually assess that and also assess the context and where the organization that we are implementing the CRP, what's the context of where the organization is overall, and what are the gaps that we need to close in order to have effective implementation. Next. We'll also be assessing the processes of what we put in place, using high reliability to make sure that the workflow is accounted for, and can it be accounted for as we roll out new changes in processes. Measurement, I already talked about, and then person-centeredness, how engaged patients and people are in the creation. What we find is when our safety initiatives are involving and based on patients who have actually, who can participate, those are the interventions which are adopted much more easily. Next. So we put together a series of metrics. You can go to the next slide. there are four big buckets that we will bring to the PACT Collaborative. There's a metric on environment, which will tap things such as the culture of the organization, culture of safety, and also looking at just the number of adverse events. We'll also look at those events which are what we believe are they eligible for a CRP case, and how many of them actually became CRP cases. The steps looks at much more specific, like timeliness of communication, the timeliness and the reporting of the event analysis, of peer support, and then the resolution and the outcome. We have a domain around how do we manage serious safety events? How well do we communicate? And specific measures around communication and system improvements, where we're identifying and how do we identify and move those system improvements. And then finally, metrics on outcomes, looking at the total number of claims, the total defense costs, and the experience of both providers and patients who have had and been involved in a harm event. Next slide. This is what we are mocking up. This is a dashboard that we'll be using throughout the collaborative, which will give each organization a quick look of how they're doing along these domains in terms of the CRP environment, how many of the cases that we think are CRP eligible have gone through, the CRP steps, how are we doing in terms of reporting, event analysis, and resolution, how are we doing in terms of managing events, and then finally, what are our outcomes in terms of experience, as well as how are we hearing about new claims that we were surprised that we heard about, that there was no knowledge, and overall, how are we doing in terms of our serious safety events and claims. So this profile will be put together and allow organizations to see how they're doing for internal improvement, as well as fodder for opportunity for learning from others who are participating. Next slide. All right, well, that is sort of a lot of the detail of our collaborative. Thank you very much. I'm going to turn it back to Melissa to talk about some of the program information.
Awesome, thank you, Evan. So I just want to talk with you all about what it would actually be like to participate in the PACT Collaborative, give you a little bit more information about that. Next slide. First of all, we want you to know that joining the PACT Collaborative, you'll be joining a really robust and varied cohort of organizations that are really sharing this commitment to developing comprehensive, highly reliable communication resolution programs. At this point, we have 11 organizations that have committed to participation, and they are bringing along 27 different facilities from children's hospitals, senior care facilities, and acute care hospitals. We've also had advanced conversations with another 15, I think maybe even more than 15 organizations that are expressing really strong interest in participation, maybe working on applications now. And we do, just so you're all aware, we do need to cap our participation at about 25 organizations because we are committed to providing a lot of individualized support. And we want to make sure that we're able to do that with the faculty and resources that we have. Next slide. So our PACT learning session dates. Our first learning session will be in January. That is our learning session specifically for executive sponsors and team leaders. And then each of our other learning sessions will happen every few months with our action periods in between, as you heard. These dates are available in many different places. One thing I do want to stress is that our learning sessions will all be virtual. They will all take place in half-day increments so that you're not sitting in front of a screen staring at talking heads all day. They will be interactive, so there will be limited talking head staring. And because they are virtual, you do have the opportunity to bring additional people with you. So when normally you're participating in a collaborative and it is face-to-face, just your small core team attends. Because this is a virtual experience, we'll be able to share agendas ahead of time. And if there are additional people from your organization who would benefit from a particular element on the agenda, you can invite them. So we hope that will allow for broader adoption of the CRP as you're going along because more people can be engaged. Next slide. people are often curious about what the time commitment looks like. We think that executive sponsors will need to attend that first learning session in January, and then they will need to be participating in regular meetings with the collaborative team, or possibly just with the collaborative team leader, and may want to participate in faculty consultation. Our executive sponsors are the people who need to be sort of providing some of the vision, and they need to be poised to remove the barriers that the team encounters. So they need to know what's popping up. We think that can probably be done in about 30 to 60 minutes per month. Our team leaders are the only ones who will attend all 5 learning sessions, and they will also participate in monthly meetings with the collaborative team. When faculty consultation is needed, they'll be very involved, and they'll also be the ones who are collecting and submitting data. We think that will probably take about 3 to 5 hours per month. The rest of the members of the team, so people from maybe from risk management, from claims, from patient relations, your frontline clinical staff, your patient and family representatives, they will participate in the final 4 learning sessions. And they will also participate in monthly meetings with the collaborative team, and faculty consultation is desired. So that might be sort of 1 to 3 hours per month. The other time that will be invested in participation in the PACT Collaborative, we think will actually come from the time that you're already investing in CRP activities. We're going to be providing you with the tools and resources and new ideas to do what you're already doing better, use your time more efficiently. Next slide. So to join PACT, we do have major sponsorship, which has allowed us to really keep our tuition low. And this collaborative is being convened by 3 nonprofits. So we're not making money on this. We are simply covering our costs. For an organization to join, it costs $20,000, and that includes the participation of 1 facility. And then any additional facility within that system, whether a hospital or an additional senior care facility, would be an additional $7,000 per facility. Next slide. So next steps, if you are interested, we would be happy to talk with you anytime. We could talk with some of your colleagues. We'd be happy to set up a Zoom to share this presentation or another presentation to talk more about the details. You can send some information or send an email to the CAI@uw.edu to request some more information. You can also get an application from our website, which is ariadnelabs.org/PACT, and submit that to the CAI@uw.edu. Applications are due by December 3rd, and we will be selecting and notifying participants on a rolling basis, but with final letters of acceptance sent no later than December 10th. And then we'll be launching, as we've said, in January. Next slide. So I would now like to turn it over to Nicole Moore, who is the Continuing Education Coordinator for the Collaborative for Accountability and Improvement, and she'll be facilitating our Q&A.
Thank you, Melissa. While everyone starts thinking about all the questions that they have, I do want to say that I would be happy to send out the slides after this meeting. And also, while you get your questions ready, I do know there was a question that came in, Dr. Benjamin, while you were speaking, and Cooper J wanted to know how you are defining adverse events.
Well, actually, we have a slide for that. That was our slide that we pulled out, Nicole. I don't know if we could pull that back. We didn't want to get it too much to the detail. So I'll just say one thing. It's important, maybe as Nicole finds that slide, we can share it with you. We really thought it was important in the collaborative that we have some standard definitions. Definitions of what a serious safety event is, and then definitions about what an eligible CRP case would be. And by everyone joining the collaborative, we would use these standardized approaches. And so, for instance, in the measures, when we talk about these events, it's one having a standard definition. Everyone will be able to track how they're doing in terms of numbers of events, and then eligibility of those events for CRP and how we define what is a CRP eligible. Do you have that, Nicole?
Yes, I do. Let me pull it up right now.
So this is maybe a little too much detail for all of us here, but we talk about this CRP eligible event as an adverse event that's known to the organization that meets a number of different criteria. One is that there's harm that's judged by the team to be at a level in the HPI safety level of a PSE 1 or higher, and we can share those definitions, or that the patient is reporting a harm event that is at a level 1 or higher, or that the patient or the family requests that a CRP used to respond, or there's written demand for payment, essentially in a pre-litigation notice or a written demand. Those of how we're defining a CRP eligible event, and then the actual event of a serious safety event being judged by that HPI level 1 or higher. Then we have a CRP actual event, and then the serious safety event here is this general definition of a deviation from practice, that not only was there a deviation from practice, but that deviation reaches the patient and cause the harm. It's very specific. It must meet both of those criteria. So those are just some of the definitions that we will use in our measurement as we go forward.
And Evan, if anyone's not familiar with what a PSE 1 event is, that's the HPI's minimal permanent harm level. And so it would be any event that's minimal permanent harm, and then moderate or severe temporary harm, moderate or severe permanent harm, and death would be the what that harm threshold cuts at. Nicole, while you're waiting for questions, I did want to add a major thanks to our two sort of flagship sponsors, Liberty Mutual and Constellation Mutual. They have made major contributions that offset almost half the cost of the budget, and that's one of the reasons we're able to bring this to you at such a reasonable tuition rate. So think good thoughts about Liberty Mutual and Constellation Mutual, and thank them for their support.
You can feel free to unmute yourself if you'd rather ask your question instead of typing it into the chat box. Okay, we have a question from Pamela Pop. Do you anticipate this being expanded as to the volume of participants or a subsequent class?
I can, or Evan, do you want to go, or would you like me to?
Yeah, I mean, right now, yes, we're limited to this initial class. It's an 18-month with the number of participants limited capped at 25. Our long-term goal, though, is to continue to spread and scale CRP. But for the next 18 months, we're starting in January, this will be the work. We don't anticipate expanding it during that 18-month period. Tom?
No, I would have said exactly the same thing. So we hope this is the start of a series of PACT collaboratives, but we want a focused group of early committed organizations, and can potentially expand down the road, but don't currently have plans for that.
And just in case the numbers I provided were at all confusing, I want to be clear that right now, while we are capping at 25 organizations, we have 11 committed organizations that represent 27 facilities. So we do still have capacity for more organizations to join us. We think we may ultimately end up with 40 to 50 facilities from 25 organizations.
We do have another question. Is there a specific Just Culture algorithm that will be used for the culture piece of the program? Evan, I don't know if you're able to expand a little bit on the culture survey that's going to be used.
So, I mean, for the culture survey, most organizations are using the AHRQ culture survey. And so rather than adding a burden, we'll most likely be using the AHRQ culture of safety survey for the organizations.
And then Evan, I think the question was also about, do we have a fixed just culture algorithm that we would be recommending that folks use? And this is an area where Allison's point about sort of local adaptation is particularly good. There are a variety of equally effective just culture algorithms that could be used to accomplish the principles that we're trying to outline. So I don't envision that any organization would need to abandon a just culture tool that they're currently using and use a new one.
This is Jill Cooper. Can I ask a clarifying question, please? Regarding the culture survey, because the teamwork and safety climate culture for our system is embedded in our caregiver engagement, and we use the SAQ. We use the abbreviated SAQ. I can see there being reluctance from a system to introduce another type of survey tool around that because of the ability to compare and measure over time improvement. So I'm just curious whether I misunderstood, or is part of this going to be introduction of another survey tool? And if so, who does that tool go to?
It will not, Jill, involve a new culture tool. We'll just have a crosswalk. So whatever culture and climate of safety tool measurement approach you're using, that data can be then fed into the PACT process. So no need to do anything new.
Thank you.
We have a lot of opportunities. I think Melissa had outlined our process for getting more information. The deadline, we now have it December 3rd for final applications, so keep that in mind. Our team, though, is very happy to come and sit and talk with your team, your senior leadership team, about more details. As things come up, please email us. I think you have our email if there's any questions, anything you want to set up. But we're very excited by this. We're very excited by the reception that we've had, and we'd love to be able to talk more for anyone who's more interested in hearing about the details that would be for you.
We do have one final question that came through. Is it possible to adopt the program in one or two of our facilities first before expanding the program to all of our facilities?
I would say that's a common approach. Actually, several of the committed organizations are starting with 2 or 3 or 4 or 6 of their facilities with the intention of expanding after that. All of the change package, the tools and resources are intended for the organization to use going forward. And so it would be great if organizations brought sort of a vanguard of a few of their hospitals with an intention of expanding to the rest of their system going forward. I think that's likely to be the most common approach rather than trying to do wholesale implementation at the across a system all at one time.
Well, I've included our email address in the chat. If you'd like to schedule time with any of the faculty to talk in more detail about the program, I'd be happy to arrange that. As you can probably tell, this is being recorded. So once the recording is uploaded to our YouTube channel, I will share it out with the slides with everyone who is in attendance, in case you want to pass it on to some of your colleagues to take a look at as well.